Clinical Evaluation of Glaucoma, Chapter 3, BSCS Series Review. Glaucoma management involves review of the patient's history, clinical evaluation of the patient, and evaluation of ancillary testing that is done to help diagnose and track progression of the disease. Remember the three things: pressure, disc, and feels. This talk is going to focus primarily on the patient's history and clinical evaluation. Ancillary testing will be the subject of other talks. For the clinical evaluation, one needs to perform a full history as in any other medical exam: chief complaints, symptoms, ocular history, etc. This list is that taken from the BCSC series. In addition to the general medical and ophthalmologic history, the following information specifically regarding glaucoma status and history should be put into each initial note when examining a patient: the duration of the patient's glaucoma, how the diagnosis was first made, and how the patient has been treated to date, what medications are currently being used, what medications were used in the past, and why any such medications were discontinued in the past. With regards to how the glaucoma has been treated, you should make comments regarding compliance with medications that are currently used. Did the patient use the medications today or last night? Has the patient ever taken pills for glaucoma? And has the patient ever been treated with laser, specifically ALT or SLT, which can oftentimes be difficult to appreciate on clinical exam? You want to know if the patient has had any prior incisional glaucoma surgeries. Again, with the development of non-penetrating procedures, this may not be clinically evident on exam, or at least can be easily overlooked. You'd like to know what the peak intraocular pressures have been in the recent past as well as prior to treatment. And for those individuals that seem to be having progressive damage or damage with normal intraocular pressures, you may ask a number of questions which allude to non-pressure related problems which could either mimic capital POAG or place individuals at risk for normal tension glaucoma. Those items are listed here. On clinical evaluation, it's important to remember that you want to go through all segments of the exam, just like any other eye exam. Every portion of the exam can yield pertinent information for the evaluation of glaucoma patients, starting with refraction. This is extremely important for those that are being considered for narrow-angle glaucoma, as hyperopia is one of the primary risks there. Starting with the clinical exam, one should look at the lids. You can see findings frequently related to medication side effects here, as shown in these two images. You can also see other findings sometimes on the external exam or skin, which can cause secondary glaucomas. Here we have the adenoma sebaceum of tuberous sclerosis. These can sometimes be associated with anterior segment neovascularization and secondary glaucomas. In this image, we see the typical S-shaped lid deformity of neurofibromatosis, and on the image below you see the cafe au lait spots that can frequently be seen with this disease as well. Neurofibromatosis can cause a secondary glaucoma via various mechanisms, including outflow obstruction, elevated episcleral venous pressure, as well as neurofibromas in the angle obstructing outflow directly. In any case, one should be familiar with the lid deformities that are present with this disease and are associated with a higher risk of glaucoma development. Juvenile xanthogranuloma can often be seen with these yellow or orange papules on the skin of the head or neck, and again, this can often cause a secondary glaucoma, often associated with a spontaneous hyphema. Oculodermal melanocytosis can be seen in individuals and can also cause a secondary glaucoma. Frequently there is increased skin pigmentation in the periocular area. In this photo, the image or the left eye is the affected eye. Sturge-Weber syndrome also can be seen to have periocular skin changes, in this case the facial hemangioma. Glaucoma is associated typically with elevated episcleral venous pressure, but may also be due to angle abnormalities / immaturity of the angle. Axenfeld-Rieger can also have a number of facial or external findings. Typically they'll have dental abnormalities, hypodontia or microdontia. They can have malar hypoplasia as seen in the profile images here. Glaucoma occurs in 50% of these individuals. Orbital varices can sometimes as well be associated with a secondary glaucoma. You'll typically see dilated eyelid veins and intermittent unilateral proptosis. I do not have a good image of that at the moment. AV fistulas can cause a similar elevated intraocular pressure, again due to a secondary increase from elevated episcleral venous pressure in the acute setting.